Yes, Mega, you are live now. You can start the session.
Okay. Okay. Hello, everyone. Good evening. This is Megha Sa, and on behalf of ForOptom team, I welcome you all on this e-learning session. So, short intro about our program. The e-learning session is an initiative by ForOptom. This is an interactive program where we discuss about optometry topics. And today's speaker, we have Mr. Sayan Mukherjee on the topic of why vision therapy is important. So before moving to the actual talk, I'd like to give a brief intro about our today's speaker. Mr. Sayan Mukherjee is a postgraduate in optometry and currently he is a head of department in Nandadeep School of Optometry, unit of Nandadeep Eye Hospital. He is also a member of IACLE and specialized in contact lenses and orthoptics. So, on behalf of ForOptom team and our lovely audience, I welcome you, sir. Over to you.
Thank you very much, Megha, for your wonderful introduction. I'm very happy to give a talk on this session. Thank you very much for Optom team for this great initiative to interact all of you. So let's start today's session. Today I am going to discuss briefly about vision therapy. It's difficult to cover all the aspects of vision therapy in single presentation. I will try to cover brief concept of VT, including principles and indications. Behavioral optometrists believe that vision is a learned skill. Vision plays the largest role in learning. There's more to vision than just having 20 by 20 eyesight. A strong visual system is needed for reading using a computer and playing sports. The definition denotes basically, in spite of having 6 by 6 vision, there may be requirement of vision therapy. For examples, to rule out and manage ocular asthenopia, computer vision syndrome, sports vision, etc. Irrespective of vision may require vision therapy to make patients asymptomatic visual, perceptual, motor abilities. Here we have ingredients for salad. We can able to see two pictures. Left side, the dishes of salad looks more delicious than right side. Though the ingredients are same. The dishes of right side include finer adjustment of ingredients. Same manner, today's lifestyle demands finer vision means our visual demand has been increased. Here to read these jumping letters, we need to concentrate as well as more focusing ability is required. This is actually known as dynamic visual acuity, which is very important for sports person. Besides static visual acuity, today's lifestyle also demands dynamic visual acuity. A person who is 20 by 20 with excellent visual acuity can have deficient visual skills because skills are not closely correlated with acuity. Besides acuity, skills are also depend on eye-hand coordination. Vision therapy helps to improve eye-hand coordination. Ocular motor skills or eyes physical abilities, visual perceptual skill or ability to process information. These both are equally important for binocular single vision, such as motor and sensory fusion both are crucial. If there is deficit of any one, there will be symptoms. Now, there are the ocular motor skills which are very important to maintain binocular single vision. These skills are required for both static and dynamic visual acuity, which with increasing visual demand, vision therapy may require to improve ocular motor skills in spite of having normal range of binocular single vision. Acuity, ability to see clearly both far and near, that means focusing ability, attention, ability to stay on the task, binocularity, aiming and using the two eyes together, that is binocular single vision, depth perception, that means that is perception of 3D image, fixation, ability to quickly move your eyes from one spot to another, that is ability to focus, focusing, keeping images clear and both far and near, that is accommodation facility, peripheral vision, ability to view interpret your surroundings. Tracking, ability to follow moving objects. That means that is saccades and pursuits. Visual perceptual skills. Visual perceptual skills are sensory skills. Sometimes vision therapy is required to improve all these abilities in spite of having normal ocular motor skills, such as some patients may have deficit of sensory fusion in spite of having good motor fusion. Form perception, hand-eye coordination, spatial ability, visual memory, visualization. These all are needed for visual perceptual skills. Orthoptics. The word orthoptics has derived from the Greek word orthos, means straight, and opticus means relating to light. We use glasses, prisms, and exercises for changing the pathway of light way to make the eye straight. Formerly, the aim of vision correction was to make the eye vision more clearer. Eventually, in 20th century first half, it was clear plus comfortable vision. Today's lifestyle demands clear plus comfortable plus efficient vision. Actually, this is the aims of vision correction. That means this is the evolution of vision correction. Now, the principles. To understand vision therapy, we need to know principles of vision therapy. According to patient, we need to choose various diagnostic and therapeutic tests depending upon the different principles. Haploscope. Haploscope tests have two fixation targets, one for each eye, and the targets are moved separately to align with each other. The example of haploscope principle is cyanotophore. Diplopia test, where there is one fixation target that is viewed by both eyes. The diploscope test is, for the example of diplopia test is when we are checking NPC with the help of any push-up test like pen push-up test. Physiological diplopia is a normal phenomenon in which objects not within the area of fixation are seen as double. Usually it is suppressed centrally and does not impinge on. The example of physiological diplopia is Brock string. Stereogram is an optical illusion of disk created from a 2D image. When the image is viewed correctly, those images appear to float above the background. The example of stereogram test is like CAT card or lifesaver card, etc. Dichoptic is a very popular nowadays. Dichoptic is viewing a separate and independent field by each eye. Dichoptic stimulation is a form of visual stimulation in which different stimuli are presented simultaneously to each eye. Actually, the base of dichoptic stimulation is the contrast sensitivity, the adjustment of the contrast sensitivity. Now, the distinction between vision therapy and orthooptics. This slide depicts that vision therapy is comprehensive management, whereas orthoptics is part of the vision therapy management. It is a program, vision therapy is a program of care used to develop, restore, or enhance visual function and performance. Orthoptics means straightening of the eyes is limited to eye exercises to treat eye coordination problems by increasing the range of binocular fusion. Vision therapy is prescribed to develop or remediate fundamental visual skills and abilities, improve visual comfort, ease, and efficiency, or to improve cognitive process, visual information, and uses it to direct and monitor actions. Orthoptics is only one of many therapies which are used in contemporary optometric vision therapy. That means we can say all the vision therapies are orthoptics, but all orthoptics are not vision therapy. Grouping of optometric data are very important for diagnostic and management as well as research purpose. For accuracy, it needs clinical efficiency and practice. So we need to check very promptly in our OPD, positive fusional versions, negative fusional versions, accommodative function, motor system, vertical versions, and motor alignment. Now we need to know the indications of the vision therapy. Accommodation dysfunction, vergence dysfunction, intermittent squint, whether it is divergent or convergent, microtropia, pre and post LASIK, latent squint, paralytic strabismus, fusional maldevelopment nystagmus, ocular asthenopia. So before going to another slide, I'd like to just tell you that accommodation dysfunction, we need to check all types of accommodation dysfunction, accommodation tests like NRA, PRA, accommodative spasm, accommodative infacility, accommodative lag. We need to check all these things. Vergence, we need to check vergence with the help of prisms. We need to grade the IDS to know the prognosis of the IDS with the help of vision therapy. And pre and post LASIK, as all of we know that the status of the binocular vision in emmetropic condition and the ametropic conditions are different. That's why pre and post LASIK we need to verify the binocular vision status. Latent squint, yes, definitely. Sometimes phoria bakingtropia may occur in future. So for that purpose, we need to know the status of the latent squint, and we need to know whether it is compensated or decompensated heterophoria or not. Paralytic strabismus, in case of paralytic strabismus, we need to know the particular, we need to identify the particular muscle palsy. And if we identify the, if we are able to identify with the help of vision therapy test the particular muscle palsy, then we need to do some tests to document the amount of muscle palsy. For the, and for follow-up purpose also, we need to document again to see how much is the improvement actually. Fusional maldevelopment nystagmus is nothing but the latent nystagmus. Now, ocular asthenopia is a very broad term. Any type of computer vision syndrome, dry eye, or any other types of asthenopia also may relate to ocular asthenopia. So we need to evaluate with the help of vision therapy diagnostic tests whether this asthenopia is related to ocular or not. Now, occupational therapy means in different type of occupation, we need to verify whether there is any requirement of vision therapy or not. For example, some person is having a good vision with 6/6. Another person is having good vision with 6/6, but these two person may have different visual requirement or different demand of vision. For example, somebody is using computer throughout the day, near about 10 to 12 hours. For this particular person, the demand of the accommodation facility will not be equal another person who is doing the outside work. So depending upon the visual status, not only visual status, the vision may be the 6/6 for the both the person, but depending on the visual demand, especially the non-strabismus binocular vision disorders demand, we need to identify the patient where we have to check the vision therapy. Computer vision syndrome, learning disorder, for example, dyslexia, amblyopia, we need to check the status of them. Not only we have to do the amblyopia workup. So during the amblyopia workup, besides refraction and other workup, we need to check some additional tests like vision therapy diagnostic test or OCT to know whether there is any eccentric fixation or not. Even we need to check about the during the vision therapy diagnosis, we need to check the scotoma size also. Depending upon the scotoma size, we can explain the patient about the prognosis of the amblyopia. Definitely specially challenged children, better to tell these patients like differentially able children. That is much more good thing to tell about these patients. And we need to keep patience to evaluate this patient, and we need to do vision therapy diagnostic test for this patient very carefully. Now, some important tests which can help in the OPD in the clinic to do to identify or to screen the patient for the vision therapy. Covert test. Among the covert tests, alternate covert tests are the most important to identify whether there is any phoria or not. Near point of convergence, we need to check break and recovery. Vergences, with the help of prism bar, we can check the positive and positive fusional vergence and negative fusional vergence. Vergence facility, with the help of 8 prism diopter base in and base out, immediately we can check the status of the vergence facility. Accommodative facility and stereo acuity. Stereo acuity is very important to know the prognosis of the amblyopia treatment. Accommodation facility is also very important. In today's lifestyle, I think in spite of having good near point of accommodation also, if somebody is having lacking accommodation facility, we need to give vision therapy. Duane has been classified very nicely that NSBD, non-strabismus binocular disorders. And I think this is very volatile. Sometimes I also forget the things. So what I do actually, I take a printout of this and I stuck in my OPD to compare the things regularly in the OPD. So this is the classification with the which Duane's has been explained. So there is a convergence insufficiency, divergence excess, basic exophoria, convergence excess, divergence insufficiency, basic esophoria, vergence insufficiency, vertical phorias. So what is convergence insufficiency actually? Convergence insufficiency type phoria means that there will be two things may occur. With the help of alternate cover test, you have to see whether there is evidence of phoria or not, and then you have to do with the help of prism bar cover test or any other test which can help to identify the phoria or to identify the amount of phoria. Then you can easily come to know about the, after coming to know about the amount of phoria, you can easily identify whether the phoria is more in the near or distance. In case of convergence insufficiency, the phoria will be, the amount of phoria will be less than near and more than in far. And sometimes it may occur, sorry, I've done the convergence. In the case of convergence insufficiency, the amount of phoria will be more in the near and the amount of phoria will be less in the distance. Sometimes it may occur, distance will be ortho and near will be exophoria. So in case of convergence insufficiency, to identify it easily, you have to see two things. Number one, there will be exophoria, which will be greater in near, lesser in distance. Number two, there may be exophoria for near, but orthophoria for distance. This is the basic thing. Divergence excess, you have to identify again two things, whether the exophoria will be more in distance and less in near, or more in distance and ortho in near. Basic exophoria, the near exophoria will be equal to near distance exophoria. Convergence excess, this time there will be esophoria. Near there will be more esophoria than distance esophoria. Divergence insufficiency, there will be more esophoria in distance and less esophoria in near. Basic esophoria, there will be equal esophoria, amount of esophoria for distance and near. Vergence insufficiency, that means whatever is the normal range of positive and negative functional vergence, the patient is not achieving that. Yeah, the questionnaire is also very important. I follow some questionnaires during my OPD, and if you take a very good history and if you take a very good questionnaire, then you can cut down your binocular vision test modalities actually. That means the amount of test. Then you can just do only which tests are required. Okay. Some basic questionnaire, what I do actually, you can frame your own questionnaire also. Do your eyes bother you? Do your eyes bother you? Do you ever get headache? How long can you read comfortably? When you read, does the print ever blur, double, or move around? Do you experience motion sickness? So these are the questionnaire. Okay. So this you can frame by yourself also as per your OPD. Clinical science used for diagnosing accommodative binocular anomalies. In NSBD, the most important thing, in spite of having ortho position also, that means there is no manifest deviation, we need to consider the non-strabismus binocular disorders, which includes accommodation and different vergence anomalies. So as I have already discussed, to identify the vergence anomalies, we can use different prisms, and same way to identify accommodation anomalies, we have to do certain tests. Before going to discuss about any particular test, the most important thing to do the primary test to identify the accommodation dysfunction, that is dynamic retinoscopy. So generally we do static retinoscopy, but during the evaluation of NSBD, first of all we have to do dynamic retinoscopy. What is the difference between dynamic and static retinoscopy? There is a difference between the principles. The principle of static retinoscopy is that the far point of the patient's eye should coincide with the peephole of the retinoscope when we are not using the accommodation much. That means the accommodation will be physiological minimum. In dynamic retinoscopy, the principle will be like that. The near point of the patient's eye should coincide with the peephole of the retinoscope when we are playing the accommodation fullest. Okay. So So there are multiple process of dynamic radioscopy. Generally, I do MAME, that is monocular estimation method, that is most popular and easiest one. And besides MAME, generally we do MAF, that is monocular estimation method, BF, binocular estimation method, PRA, NRA, and even we check the accommodative facility also. So mainly we have to check MAME, PRA, NRA, and NPA to identify whether there is any accommodation dysfunction or not. I've already told you that if somebody is having normal NPA, but if somebody is having disturbances in focusing, some patients may, suppose for example, one patient is using computer throughout the day. Particular patient may have normal NPA, but patient may complain that after using of prolonged computer, he is unable to focus for distant object in spite of having normal NPA and emmetropic eye. This particular patient, we need to check NRA, PRA and accommodative facility to see whether there is any infacility or not. So accommodative facility means to focus object from one distance to another, which is more important in today's life in spite of having good NPA. So already I have discussed about divergence excess, basic esophoria, basic exophoria, and functional divergence dysfunction. So these are the data, normative data, which we need to remember. This, I know these all are very volatile. You can follow this chart. Otherwise, you can stuck this chart in your clinic to remember these data, and you can compare. Besides this normative data, I would like to share one of my experience about my practice. That during my practice, I have seen some patients may have normal range of data, but in spite of having normal range of data, sometimes I prescribe vision therapy diagnostic test or defined orthoptic test, because that solely depends on the demand of that particular person. As I have already told, in spite of having normal data also, some people doesn't require orthoptic data treatment, but some people require orthoptic exercises, even orthoptic test. Symptoms encountered in subjects with accommodation and binocular dysfunctions. These are the general symptoms which I have already generally observed in the OPD. Red eye at near, sore eyes at near vision, visual fatigue at near during accommodative excess. Convergent insufficiency patient often tells that excessive sensitivity to light, dry or gritty eyes at near vision, headache at near vision, ocular pain at near vision, visual fatigue at near vision. Convergence excess, blurred vision at near vision, blurred at near vision, headache at near vision, sore eyes at near vision, visual fatigue at near vision. Divergence excess, this is exceptional. In case of divergence excess, the eye turn notice at far distance. Basic exophoria, dry or gritty eyes at far and near vision, sore eyes at far and near vision. Basic esophoria, lack of concentration at far and near vision, ocular pain at far and near vision, red eye at far and near vision, sore eyes at far and near vision, visual fatigue at far and near vision. CI plus AI. CI means convergent insufficiency, AI means accommodative insufficiency. So sometimes we can see the combined thing that is known as CI and AI. Dry or gritty eyes at near vision, words appear to move or jump. CI plus AE, red eye at near vision, CE plus AI, red eye at near vision. Functional divergence dysfunction plus AI, visual fatigue at near vision. So this is also very important. This I follow often during my OPD. These are the revised Newcastle control score. This I generally follow to score during the when I have diagnosed that patient is having intermittent divergence squint. Okay, so for sometimes some people already ask me during my session, some of my students in other sessions are already asked me that there is a confusion between the exophoria and the IDS. Okay, so what I believe, about 4th degree of phoria, the all case we can tell about the that is known as intermittent divergence squint. But intermittent divergence squint, The home control is also very important. That means the patient's compliance or the caregiver or the patient relatives compliance. Okay, so we need to include the home control score also to identify the IDS and to differentiate between the exophoria and IDS. What is home control score? We need to ask the patient's caregiver or patient's relative. So how many times patients are the patient's eye actually manifested in the home? Okay, if it is less than 50% or 50% or more than 50%, according to that we can grade 0, 1, 2, 3. Clinic control, we have to do alternate cover test to identify the deviation or the refixation. If it is blink, if it is refixate without blinking, that means that is grade 0. If it is blink with the help of 1 to 2 blink, if it is refixated, that means that is grade 1. If it is identified as 2 to 3 blinks and after 2 to 3 blinks it is refixated, that means that is grade 2. And if it is manifest spontaneously, that means phoria breaking to tropia for prolonged time, that means that is grade 3. Same manner we have to do for distance. So any orthoptic test we have to do for near and distance to identify these things. And one more thing I would like to tell you, that during this test, patients should wear their habitual correction. And depending upon this grading, we can counsel our patients for the treatment. If it is grade 3, we need to counsel our patient maybe for surgery, because the grade 3 score is much prone to surgery. Up to grade 2, the vision therapy results are very good. In case of grade 3, sometimes we have to give combination therapy also. Now, ocular asthenopia is very important terminology in today's life. Excessive use of electronic gadgets increase the demand of visual motor abilities, which include functional and accommodative divergences. Thus, to rule out ocular asthenopia, we need to check the status of phoria, divergence, accommodation, and intermittent squint. As we already know, heterophoria is the latent squint. Phoria is a tendency towards ocular misalignment. Now, what is compensated and decompensated heterophoria? Compensated heterophoria means which patient, in case of compensated heterophoria, there will be no symptom. In case of decompensated heterophoria, there will be symptom. That means those who are having symptoms with after distinguishing of heterophoria, if we see the patient is having symptoms, that means that is decompensated heterophoria. That means the patient's functional divergence is not good enough to compensate the heterophoria. To distinguish the phoria, the most important thing is this: the cover test. Cover tests there are 3 types of cover tests. Basically, one is direct or simultaneous cover test that detects heterotropia, that is manifest deviation. Another is cover and cover test that detects heterophoria. Another is alternate cover test that detects total deviation, that means phoria plus tropia. Alternate cover test also helps to distinguish between primary deviation and secondary deviation, which helps to distinguish to suspect paralytic squint. Shear's criterion. According to Shear's criterion, if anyone is having phoria, for example 5 prism diopter exophoria, that means that person needs to apply continuously 5 prism diopter positive fusional divergence to maintain fusion, to maintain ortho position. So fusional demand is 5 prism diopter. Thus, there is need of 10 prism diopter fusional reserve unless patient will be symptomatic, and then it is called as decompensated heterophoria. These symptoms are known as ocular asthenopia. Actually, during my practice, I always follow Shear's criterion, and that helps a lot to identify the patient for the need of vision therapy. As per, so during my practice, I have seen some conventional therapies and some modern therapies also. Conventional therapies are the base of the therapies, so we need to know all the basic conventional therapies. This is a very big topic. Just I'll give the brief overview idea of the conventional therapies. Here we can able to see the lifesaver card, which helps to helps for the functional convergence exercises. And CAT card. So already I have explained the principles. So I will just mention the principle also during this therapy. Mention of this name of the therapy. For example, like the first one is lifesaver card. That depends on the physiological diplopia principle. Second is CAT card. That depends on the stereogram principle. Third is Brock string. That depends on the physiological diplopia principle. Next is prism bar, which is depends on the another physiological diplopia principle. So with the help of prism bar, we can check functional divergences. Now another is accommodative flipper. With the help of accommodative flipper, we can easily check that accommodative facility. I have already told you amplitude accommodation is very important. Near point accommodation is also very important. But according to today's lifestyle, accommodative facility is most important thing. For computerized vision therapy, 6 CPM, that means 6 cycle per minute, is the normal range of accommodative facility. And for conventional therapies, 11 CPM is the minimum range of accommodative facility. It is the patching, the conventional method of treating amblyopia. So as I have already told that in CAT card we are using stereogram principles. So I will just enumerate about the stereogram principles. Stereogram exercises are exercises for our eyes that can help to improve the symptoms of convergence insufficiency. A stereogram is two incomplete images which can be joined into one complete image and vice versa. So these are the other exercises. The first one is occluder, handle occluder. Handle occluder is very helpful. And the second one is near fixation target. Near fixation target is very, very important for orthoptics diagnostics test, during the test of dynamic retinoscopy, and for other tests also. Why you know? Because in orthoptics, we have to check any test for near and distance both. Otherwise, the test will be incomplete. Maddox wing are generally used for the to check the near exophoria, near phoria. Maddox rod to check the amount of phoria, and Thorington's card to quantify the phoria. Synoptophore, some people said that it has been obsolete, but the thing is this, still it has use. I think so. I use sometimes synoptophore to check the BSV status, as well as to check the range of the functional versions. And yes, definitely it requires patient's cooperation also. Stereoscope, it is very helpful for the amblyopia therapy. Stereoscope is very cheaper, so we can give stereoscope for any patient for the amblyopia therapy, for anti-suppression therapy. But the major disadvantage of the stereoscope is this has age limitation. Generally 8 to 10 years is the age up to which we can give the stereoscope therapy for the amblyopia. As per present scenario, there is immense importance of computerized vision therapy. There are various software available for modern VT. As per the patient's compliance, we need to select module of diagnostic tests such as computer vision syndrome, amblyopia, learning disability, for example, dyslexia, etc., etc. Modern vision therapy also provide treatment for adult amblyopia. Neuroscience has proven that human brain can change at any age. That is neuroplasticity. So now we can give therapy for adult amblyopia also. So vision therapy, which includes eye exercises, visual motor processing activities, and neurological therapies. So these are the some types of modern vision therapy which is computer based. Basically, in today's era, in this COVID situation, computerized vision therapy is utmost important to nullify the to cut the different types of tests, to do the specific test also, to do the test very fast, or to do the specific test. Modern vision therapy is very important because this is computerized, so we need very less accessories, so we can use these things in COVID era also. And sometimes we can give some home therapy throughout the internet with the help of internet for this computerized vision therapy. Okay. So computer-based convergence exercises. In recent years, a new treatment method for CI has emerged. A computer-based orthoptic program known as computer version system is used by many eye care professionals. The program uses random down stereograms. You can see here that we are using, actually we need to wear an anaglyph to see the random stereogram actually, for to see this here, to see here. So here we can see the random dot stereograms to from pictures that require bifocal fixation to stimulate the vergence system. The program gradually increases the amount of vergence required to appreciate the stereogram picture and can monitor progression online. So besides this, we use also dioptic therapy, dioptic stimulation therapy in case of computer vision therapy. Dioptic therapy basically based on contrast sensitivity. For example, sometimes two persons are having equal visual acuity but different contrast sensitivity. For example, somebody is having higher blood sugar level. That means he or she is diabetic patient, but he or she is having 6/6 vision. Another patient is having 6/6 vision, but he is non-diabetic. In this case, diabetic patient will be lesser contrast sensitivity, and normal patient will be more contrast sensitivity. So by adjusting the contrast sensitivity, we can do amblyopia therapy binocularly. So with the help of binocularly, if we do the computer amblyopia therapy, then we can achieve our binocular single vision, or we can achieve normal functional range, and we can achieve stereo acuity with the help of binocular single vision. In older, formerly we generally we did penalization therapy or patching therapy. Those all are also very good, but the thing is this: on those cases, the visual acuity may improve, but the quality of vision may be compromised because lacking of stereo acuity. To achieve stereo acuity, we need to give therapy binocularly. Okay, so by adjusting the contrast, we can easily give amblyopia therapy binocularly, and we can achieve binocular single vision. This is the main advantage of the computer-based therapy or dioptic therapy over the monocular amblyopia therapy or anti-separation therapy. So what I do actually during the amblyopia patient, I check OCT whether the morphology is okay or not. After doing OCT, I check with the help of visuoscopy or with the help of OCT also, that whether there is any eccentric fixation or not. If there is no changes in morphology, if there is no change in the eccentric fixation, I check the scotoma size with the help of Wordsworth dot test. If there is no, if the scotoma size is not nominal, then what I do, I check also stereopsis, and if I found there is no stereopsis, then I go for the vision therapy, and after vision therapy again I do all these tests, and I see how much is the changes. What I have found in my practice, I am practicing vision therapy since couple of years, and what I have found after giving the binocular vision therapy with the help of computer therapy, with the help of adjusting the contrast sensitivity, the yes, the stereopsis is easily achievable actually. This is the actually big breakthrough of the modern computer therapy. So this is the take home message. I know I have discussed so many things, but in spite of that, what I always remember, only this thing, this particular and this certain things I remember during my practice. And this chart actually helps me to counsel my patients also. So lazy eye, at a glance, I can say lazy eye, headache, near vision, blurring of vision, eye strain, diplopia, asthenopia, and squint. These are the deferral hands which we can promptly diagnose or detect in the OPD to do vision therapy. So take home message, indeed, to understand all principle, patient selection is very, very important, because we need to do counsel for the prognosis, need to framework diagnostic and management protocol for each patient, because we have very less time in this COVID era. And conventional VT is based, yes, we can go for the vision therapy for modern therapy, but we need to know the conventional therapy, because unless and until we know the basic principle, we can't understand the higher principles. Need to know modern and computerized vision therapy. Most important, need to understand basic kinematics of binocular single vision and ocular motility, strabismus, etiology, ocular asthenopia for vision therapy practice. References, these are the references which I already This I follow generally. These are my team, and very soon I am also introducing my other faculties with all of you. And thank you very much for Optom for giving us the opportunity to explore my skills in this platform and to share my knowledges. And don't forget to think about the COVID situation and avoid social distancing, continuously clean your hands, use proper disinfectant and symptoms. And if you have any symptoms, please visit your doctor. And foremost, I would like to say that during this COVID situation, you need to rectify your patients, you need to rectify your practice model, as well as you need to know much more thing for modern VT to make it computerized. Thank you so much.
Thank you, sir. It was a wonderful presentation. So now we can move on to the discussion session.
Definitely. Then I can, yes.
Okay, so
Just a
till
minute.
now we didn't have any questions, so we will wait for 2 minutes.
Sure. Megha, are you able to see me?
Yes, sir, I can able to see you. Your video is on.
If you have any question, Megha, you can ask me also.
Sure, sir. You just now you said in your chat PPT, like we need to get a head posture and eye to coordinate vision therapy. Can you please explain it that again?
Yeah, sure. I can explain you easily. So sometimes, for example, you need to know about the eye-hand coordination. Am I right?
Yes, sir. Please continue.
Yeah. So I'm giving one example. Okay. One cricketer. Okay. Suppose one cricketer or any pro sports person who need to just improve their skills, not only in aspect of visual acuity, not only in aspect of visual demand, they need to simultaneously uh, coordinate their hand with their visual system. So improve the visual skills with the correlation of their occupation is known as eye hand coordination therapy. Got my point?
Yes, sir. Hello.
Yeah, please tell me.
Yes, I got your point. We didn't get any question till now, so we are on the end of session. I request you to share your experience today on this session.
Yeah, it was a wonderful experience, Megha, and thank you very much for Optom for this opportunity, because I'm practicing since past 12 years, and this basically I'm very happy to share my knowledge as well as my experience to my juniors and my colleagues, and I need feedback on my session, and all the feedbacks are very welcome. If you gather some questions for me in future also, that will be helpful for me to rectify my practice also, and hope all of you are fine in this COVID area and take care of yourself and have a nice time, and all of you start practicing VT. All the best.
Thank you, sir, for your kind and lovely words here and your valuable and experiences you share with us today. I thank our audience too for being so attentive. So at last, stay tuned for more session and program. And to get updates, follow us at www.foroptom.com and also on social media like WhatsApp, Facebook, and Instagram. Thank you all. Thank you, sir. Stay safe.
Thank you.